Hi, I'm Rui Pereira da Costa, organizer of the ENO Masters 2015. This lecture will be held by my colleague and friend Jorge Martins from Portugal. Jorge post-graduated in endodontics in the New York University College of Dentistry, and he is a true endodontic scientist by heart. He is author of several impactful papers in peer-reviewed magazines. One of those is a very important review about the clinical efficacy of the electronic apex locators, published in June of 2014 in the Journal of Endodontics. Jorge's lecture will be exactly about this topic, and he'll describe the building of his paper and the conclusions we may take. I'm sure this lecture will be loved by every clinician who likes innovation, science, accuracy, and cars. You'll understand why in just a minute. I hope you enjoy.
Hi guys, my name is Jorge Martins from Portugal and I hope you have enjoyed my introduction video. So, Rui Pereira da Costa has invited me to come here to the International Endodontic Masters and present to you our work that has been recently published in Journal of Endodontics about electronic apex locators. Basically, we have performed a systematic review comparing in vivo two techniques of working length measurement, the electronic method and the radiographic method. I have built this presentation and divided it in three parts. The first part will be a systematic review where I will try to show you what we have done. It's a more evidence-based dentistry part, more oriented to literature review and a little bit more turned to the ones that have already some experience working with electronic apex locators. Then we will have a second part where I will try to give you a clinical recommendation about which technique is better to perform the working length measurement. And then we have a third and final part for the ones that are now starting with this technique of the electronic method to achieve the working length measurement, where I will try to show you how you should read your apex locator and what is an expectable behavior from this kind of devices and some behaviors that may not be so normal, may be more atypical. And what do this type of behaviors mean and how you should approach this kind of situations. I hope you enjoyed what I have prepared to you, and let's have a start.
Than the yellow marked soft tyres, and the other thing, Crofty, is it gives you a few metres off the start, the stickier tyres, and that's critical here, isn't it? Getting down, it's quite a short run down to the first corner, so a set of stickier tyres will definitely gain you 3 or 4 metres or half a grid slot. You can't afford to give that away, otherwise you'll be losing position.
It's 285 metres down to turn 1. Is that enough time, I wonder, for Sebastian Vettel to mount a challenge to try and get past Maldonado on the right-hand side of the grid, where they say it's worth an advantage if you can be on that right-hand side, the odd-numbered side.
Well, you get a faster sweep into turn 1, so it's not only...
Before we go with the systematic review, let's just perform here a short introduction to the working length. I have found during my years of practice that different clinicians like to finish the root canal at different levels of the root canal. Some prefer to finish it a little bit shorter than the radiographic apex, others like to finish it at the exact point of the radiographic apex, and others like to go a little bit further than the radiographic apex, what is usually called the puff of Sealer, because they believe that that condition favors the prognosis of the root canal treatment. Well, I believe that the root canal instrumentation, whether it is the mechanical instrumentation, the root canal disinfection, or the root canal filling, should finish it a little bit shorter than the radiographic apex. It should finish it in an area of minor diameter that is usually called the apical constriction. And the apical constriction we know already from several studies, including the study from Professor Cutler. The apical constriction is something like 0.52 millimeters shorter than the apical foramen, which makes it also a little bit shorter than the radiographic apex. So which techniques do we have to determine the working length measurement? We have the radiographic method and we have the electronic method, basically with the electronic apex locators. To understand a little bit what is being said actually about electronic apex locators, we have performed a search about systematic reviews and meta-analysis on this subject. And we were able to find only 2 relevant reviews through 7 electronic databases very recently. And the papers available are from Ahmad and Pani on primary teeth, and the paper that I'm bringing you today and that I'm presenting you. So I will go very fast through the study design that we have applied, because this may not be so interesting for the ones that are looking more for clinical advices, but I really would like to share this with you. So we have performed a PICO question, that is a type of question that is performed on scientific papers, and we have performed the design of the search strategy based on 3 types of searches. A search in electronic databases, a manual search, and a contact with authors from previous studies that may know some papers that we were not able to reach in the previous two searches. So we have identified the keywords and the mesh terms that we have applied in each electronic database that we're looking for. We applied also filters and limits so that all the papers that we were collecting were as similar as possible from between them. And then we have analyzed the titles and the abstracts, the relevant papers. We have analyzed the full text, and to the ones that were relevant, we have applied a scientific evaluation method through the CASP questionnaires, and we have performed a manual search, and we have contacted the authors. And we have achieved a certain amount of papers that we have analyzed, and to all of them we have applied limits and criteriums so that all the papers, as I said before, all the papers could be as similar as possible between them. And we were able to find 53 papers that some of them were excluded, and to all them we have applied the evaluation of the scientific method that basically consists on a classification answering to the questions of the questionnaires, and we give an evaluation to the papers, and the papers that had less than 50% of classification, we have eliminated them because they were under risk of bias, and we have a final sample of 5 randomized controlled trials and 16 in vivo diagnostic tests that were included in our review. To each one of those 21 papers we have collected all type of information that were available, and we have performed an analysis of the results. Our search was finished at July of 2013. I want to just for curiosity to see what has been published from that time to now, and I was able to find a paper on October of 2013. That was a paper that we were not able to find because our search has finished in July, so we were not able to find this paper. And we have found another one that is from 2012, previous from our search. Probably this paper just came out after our search. Some journals have a delay on the publication of papers on the electronic databases, and that may be one reason why we were not able to find this paper. But basically those two papers they just don't change very much what were the results that we're able to find. As I said before, our search wanted to find only papers that were comparing both, in the same paper, both techniques for working length determination, the radiographic versus electronic technique to determine the working length. And on the 21 papers that we were able to find that were comparing both techniques in the same paper, we were able to find globally 18 factors, 18 analyzed factors on those 21 papers. Not every paper were analyzing these 18 factors, but globally it was possible to find 18 factors that were analyzed on those 21 papers. But not all these factors were answering to our questions. Our question had two outcomes: a primary outcome that was to find out if the radiographic technique and the electronic technique had the same efficacy on the working length determination, and the number of radiographs needed to perform the working length determination in both techniques. If they require the same number of radiographs. So we had to exclude some factors that were not answering to our question. They were interesting factors, but they were not answering to our questions, so they were excluded, and we regrouped the factors into groups. The factors that could answer to our primary outcome, that was find out if they have if both techniques have the same efficacy, and on these factors we had interesting factors analyzed, like the distance to the radiographic apex, the distance to the apical constriction, the final obturation length. So these were factors that could answer in some way to our primary question. And the second outcome, well, this is more direct. So 4 papers were analyzing the number of the radiographs required in the electronic method versus the radiographic method to determine the working length. So regarding the primary outcome, one interesting factor that was analyzed was the distance to the radiographic apex. And they performed this analysis using 3 types of radiographs: the odontometry radiograph, the master cone control, and the final obturation length. Those were the 3 types of analysis they performed to evaluate the distance to the radiographic apex. So they performed this evaluation trying to find out if the electronic apex locator could give us a working length measurement that could fit in a preset radiographic range, a radiographic window that the papers considered as a security window where that working length would be a successful working length. And this preset radiographic range was variable from paper to paper. Some papers set it to be between 0 and 2 millimeters, and other papers set it to be between 0.5 millimeter and 1.5 millimeters. And this preset radiographic range makes sense because it's the range where usually we can find the apical constriction. That is basically the anatomic position that we would like to find, because it's the perfect area where we should finish our root canal instrumentation, wherever it is the mechanical instrumentation, irrigation or obturation. And this range is also a range where the higher success rates have been reported. So it makes sense to understand if the electronic technique to determine the working length measurement can give us a working length that fits in this preset radiographic range. And but the papers, basically 11 papers, performed an evaluation of this factor. All the papers had different configurations and different types of analysis, different types of devices used. So they used the Root CX, the Rapex, the Novapex, the Bingo, the Neosono. So different types of devices were used, which makes a little bit difficult to compare the results, because the device settings are different from device to device, and also the preset radiographic range was different from paper to paper. As I said, it was measured between 0 and 2 millimeters, or between 0.5 and 1.5 millimeters, and one paper considered a successful radiographic range if the working length determined by the apex locator was between 0.5 and 2 millimeters from the radiographic apex. But independently of the device used and independently of the preset radiographic range, they were able to find a very high efficacy of the electronic devices to successfully identify a working length measurement that could fit in this security radiographic window. So it's really a high efficacy for the electronic apex locators to give us a working length that fits on a radiographic interval where usually we can find the apical constriction. Another factor that was analyzed was the concordance between the values that were obtained with electronic and radiographic measurements. Basically, it's It's a factor very similar to the previous one, but the reference point was not the radiographic apex, but it was the tip of the file used for the working length measurement, and also it was a very high concordant measurements rate, so a high efficacy again. But more important than understand which technique, the radiographic method or the electronic method, can be more reliable on determine a preset radiographic range, is the capacity that these techniques have to identify the apical constriction. That is the area of minor apical diameter, because as I said before, this it's the ideal anatomic position that we should find. So the methodology to evaluate which of the techniques can perform a better identification of the apical constriction is a little bit more complex than the previous factors, because in this type of analysis, the distance to the apical constriction, we must perform a determination of the working length using electronic devices and radiographs, and then we must have the tooth extraction and evaluate through histological cuts which of both techniques is better. So we only have four papers that perform this type of analysis, and these papers have contradictory results. Hassanian in 2008 performed this comparison between the electronic methods. In this case, the author has used the root CX apex locator, and he found out that in average he could find the working length measurement could have a distance of almost 1 millimeter to the apical constriction, while using the radiographic method it was possible to determine a working length measurement that had a distance of 0.64 millimeters to the apical constriction. And the author found out that there was a significant difference that favors the radiographic method. So Hassanian in his paper concluded that the radiographic method had a high rate, and it had a better efficacy to determine the apical constriction. Another paper from Kim, he did not evaluate a direct comparison between electronic method and the radiographic method. He used a comparison between electronic method versus electronic method with radiographic adjustment. So it's not a direct comparison between electronic and radiographic methods. It's more a comparison between electronic method with or without radiographic adjustment. And he was able to find that although there was not a significant difference, but he was able to find a higher efficacy to determine the apical constriction from the group that had an electronic method with radiographic adjustments. So apparently using both techniques together, it's more reliable than electronic method alone. Another paper from Vieira, 2010, with a more interesting sample with 482 teeth, has performed a comparison between electronic method versus radiographic method. In the electronic method, the author has used two different types of apex locators, the root CX and the elements, and he performed measurements in three types of teeth: the anterior, the premolars, and the molars, that are the three percentages that you can see here. And having as an example for the anterior molars, that are the first percentage that you can find here, the electronic method using the root CX was able to find in these 482 teeth, was able to find 74% of measurements that could find the apical constriction. So this is a really high rate. And using the elements, it was possible to find the apical constriction in 65% of the times. And using the radiographic method, it was only possible to find the apical constriction 22% of the times. And the author concluded that there was a significant difference that was favoring the electronic methods to determine the apical constriction. The same author, on the same paper, found also another significant difference that is very interesting. So it was on the long measurements. Using the electronic method, wherever using Hutzeschis and elements, the author did not found any long measurement when determining the working length with this type of devices, while when using the radiographic method, the author identified 35% of long measurements. The same author, 1 year later, with a sample that is even higher, almost 700 teeth, performed a very similar study, but using 4 different apical locators versus the radiographic method. And the same author was it was possible to conclude in this study the same thing from the previous study. The electronic method was more reliable on determining the apical constriction and to avoid over instrumentations. So here are the results for the apical constriction finding analysis. The author has used again Hutzeschis and elements, and he added 2 more different devices, the Precision AL and the Apex 5, and it was possible to find to all the devices results that were significantly better than the radiograph alone. So there was no difference between apical locators, but there was a difference between any of them to the radiographic determination of the apical constriction. So basically the studies, although there are contradictory results, since Hassanian concluded that the radiographic method was better, but the studies with a higher sample numbers favors the electronic method when determining the position of the apical constriction. Besides of that, there were an occurrence of more long measurements with the radiographs, and this is an important point, because the long measurements, the instrumentation with long measurements may not only destroy the apical constriction, that is an area that we should preserve, because it even favors our obturation techniques, and because the long measurements may give us the opportunity to perform long obturations, and these kind of situations are the ones that have a lower success rate on the outcomes studies of endodontics. So this is something that we should avoid, the long measurements, because it not only destroys the apical constriction, but it also may give us the opportunity of perform long obturations. That is something that we should avoid too, because it gives us lower success rates. The apical locator and the combination of electronic apex locators and radiographs apparently is superior to the electronic apex locators alone, and there was no difference between the devices. So the significant differences that were found were between apex locators, any kind of apex locators, versus radiographs, but there was not any type of significant difference between any kind of apex locators. So another point that was analyzed, another factor, was the distance to the cement and dentine junction and apical foramen. So this is not so important as apical constriction, but this was also analyzed, and there was a difference, a significant difference, that was favoring also the electronic apex locators. The number of radiographs required was our secondary outcome that we were trying to find out. So basically the electronic method significantly reduces the number of radiographs, and the electronic apex locators apparently may be an alternative to patients that cannot receive any type of radiation. Other factors that were analyzed and that were not answering to our question, but I bring them to here so we can debate some more factors, but these factors were not analyzed in our paper because they were not answering to our questions, so we had to eliminate them. But I'm bringing here so we can talk a little bit about them. So factors that don't present any kind of significance between both techniques to measure the working length determination is gender, age, tooth type, the presence of periapical pathology. This is an interesting point because the working length determination performed by electronic apex locators performs a comparison of the impedance between the oral mucosa and the periodontal ligament. And in the cases that you have a periapical pathology, you may have a damaged periodontal ligament on the apical area. So it could be expectable for us to have a difference and a lower efficacy on the electronic apex locators in this situation, but in the late studies that difference doesn't happen. So apparently there is not much of a difference independently if you have or not a presence of periapical pathology, well, independently if your periodontal ligament is damaged or not. Intracanal humidity and master cone adaptation apparently do not have any kind of difference too. So factors that may present a difference is the pulp diagnosis and the endodontic retreatment. This is not this doesn't happen in every paper, but some papers say that there are differences between the types of pulpal diagnosis and but most of the papers say that there is not much of a difference. So this may have a difference, but as I said, the majority of papers say that there is not much of a difference between the several types of pulp diagnosis or endodontic retreatment. The factors that present a significant difference is the determination and the distance to the apical constriction, apical foramen, cement dentin junction. Well, we spoke about this before, and the number of radiographs required, which in this case favors the electronic apex locators. Other factors, interesting factors, are the occurrence of now more related to the function of to the behavior of the electronic apex locators, is the occurrence of inconstant readings. So you may have, although we say that the efficacy of the electronic apex locators to determine a preset radiographic range is really high, and it may be more than 80% of efficacy, those papers exclude the inconstant readings. So we must understand this, and so the efficacy is not more than 80%. It may be a little bit lower, because as an example, Hood-Seychelles apparently may have an occurrence of inconstant readings that may reach almost 9%, and Rapex may reach almost 22% of inconstant readings. So it's not as high the efficacy as they say, but it's obviously a very high efficacy anyway. The type of apical locator, different authors have evaluated different electronic apex locators, and sometimes people ask me which type of apical locator is better. So we cannot give any kind of recommendation regarding which type of apical locator is better, because we were not able to find any difference between apex locators in the in vivo studies. There are some difference on the in vitro studies, but there is not differences. Those differences were not found in vivo studies. So if you want to give a clinical recommendation, you cannot give clinical recommendations, or you should not give clinical recommendations based on in vitro studies. You should give it based on in vivo researches. And so in the in vivo researches, it was not possible to find any type of difference between apical locators, only between apical locators and radiographs. So we are giving a recommendation regarding the type of technique used to perform the working length measurement, but not to a specific apical locator device. And these are some of the diversity. This is a clinical evaluation of the study, so the studies were not very similar between them. So sometimes it was a little bit difficult to perform a comparison. And this is the diversity of objectives and methodologies that. Regarding the conclusions and the clinical recommendation that we can give you, we can say that in the papers that evaluate both the radiographic technique and the electronic technique for working length measurement, it was possible to understand that the scientific evidence is mainly based on evaluation and comparative studies. So there are very few clinical trials, and this is also one recommendation that we have given to future researchers, that more clinical trials are, it would be interesting to have, so more clinical trials are required. And that on these studies there are some differences on the studies. They present different characteristics and different methodologies, and this is a limitation that sometimes makes a little bit difficult a comparison between studies. But although that, it was possible to take some conclusions, and the conclusions that we can have regarding the comparison between electronic method and radiographic method to determine the working length measurement is that the electronic method reduces significantly the number of radiographic controls that are required, and the electronic method is also more precise when trying to locate the apical constriction. That basically is the area that we would like to find every time, because it's the final anatomic point to where we should perform our root canal instrumentation. And the electronic method is more precise on the location of this anatomic location. But although that, the efficacy of the electronic apex locators, although it's high, it's not infallible. So as a clinical recommendation, we would recommend the use of electronic apex locators to perform the working length determination. So it would be interesting to use all the time electronic apex locators, but assisted always by at least one control, or the odontology control with our potency files, or a master cone control. And this is to minimize the possible errors of the electronic measurement. So use both, it would be more advisable. The radiographic control to decrease and minimize the errors of the electronic measurement, and the use of electronic apex locators to reduce the number of radiographs, and because it has a higher efficacy to determine the apical constriction. So our clinical recommendation basically is this: the use of electronic apex locators with at least one radiographic control.
Stand by one, give me 20 seconds.
In this last section, I would like to show you several types of behavior that you may find in your apex locator, from the most usual, normal and desirable behavior to the ones that are more uncommon and more atypical. This section is supposed to be more to the ones that are not so experienced with this kind of devices, or at least work as a revision to the ones that have a little bit more experience. Let's not forget that to use the electronic apex locators, you should avoid all kinds of metallic restorations, because it closes the electrical cycle and gives us premature apex readings. So remove, or at least avoid, all type of metallic restorations. Let's not forget too that the tooth must be in complete isolation. You should not have fluids, whether it's saliva, blood or irrigations, connecting both oral mucosa and the file that is connected to the apex locator, because what happens with the metallic restorations, This situation also closes the electrical cycle and gives us wrong readings once more. And obviously, let's not forget that a good isolation is mandatory for the root canal treatment itself, and it's not only for the electronic measurement of the root canal. So make sure that you control all variables before you start the electronic measurement of your working length. Let's take a look. So in this first clinical case, I'm going to show you what is the most regular and desirable behavior of the electronic devices for measurement of the working length. Usually what I do is I try to advance the file until the position that I get the apex reading, because it's supposed to be the most reliable measurement of the device, because it's the position where the file touch the PDL, and you get the direct comparison between the PDL and the lip clip, and it gives you the apex readings. So usually I take the file to the apex reading to get the patency also, and then I get back a half millimeter to the half millimeter mark, and that is usually my working length. So it's supposed that when you perform this measurement, you should have reproductive measurements. So the most desirable behavior of the electronic devices is when you are able to get reproductive measurements, and you can get the apex mark. Let's see what happens in this case. So I'm introducing the file for the working length measurement right now, and then I'm going to connect the electronic apex locator to the file, and then I'm going to start advancing the file inside the root canal and trying to get reproductive measurements. Let's see. So I connect the file to the apex locator, and then I advance slowly, and I can see my advancement in the electronic display of the device. And then I try to reach the apex mark, as I told you, the most reliable measurement, and then I get back to the 0.5 millimeters. Now I'm trying to do reproductive measurements. Then I get the 0.5 millimeters. This is my working length, and then I go back and try to reproduce that measurement to make sure that the device is giving me reliable measurements. And I do this 2 or 3 times, and if I see that the apical locator is very constant on the reading, I trust the apex locator, and from there I'm even comfortable with this type of readings of this, that is the full instrumentation, and perform just the control with the master cone. So when you have these types of constant and reproductive measurements, and if you trust your apex locator, and if you have already some experience, you may go full instrumentation if you have reproductive and constant readings. If you have unconstant readings, or if you are new with your apex locator, or if you are new with the technique, just play safe. Do not do the full instrumentation. Do always a radiographic control with your file that you have used to get the measurement. In most type of the retreatment cases, you have a behavior from the electronic apex locator that is very similar to the case that I have shown to you before. But in some types of retreatments, you may have a different type of behavior, and those cases usually are cases where the gutta percha filling from the previous root canal treatment is very close to the radiographic apex. In this type of situations, you may have a very fast transition from no reading to the apex reading. because when the file is inside the gutta percha you are having no reading, and then suddenly when the file tip gets out of the gutta percha and touch the PDL, you get the apex reading, and it's required very thin movements so you can get the 0.5 millimeters to achieve your working length measurement. So in this case I'm getting the patency, so I can have the apex reading, and then I'm going to try to achieve the 0.5 millimeters, and I have a very fast transition here on between no reading to apex reading, which it makes really hard to get that 0.5 millimeters that I usually choose to get my working length measurement. But with very thin movements I may get it, and hope that is a stable position. So I get here and it's not moving, so I believe it's a comfortable measurement. In this type of situations I do not advise full instrumentation, obviously, because it's very unstable, and I would advise you to perform a radiographic control with your working length file and make sure that you are in the right position to perform the treatment of the root canal. And a typical type of behavior that you may have in the electronic apex locators is the no apex reading. So this is a situation that the electronic apex locator gives you all type of measurements, including the 0.5 millimeters, but doesn't give you the apex reading, which is, as I have explained before, the most reliable reading from the apex locator. So if you have all the measurements that the apex locator can give you, and you don't have the most reliable one, I think you should doubt a little bit about the measurement that you are getting, and you should perform a radiographic control at the 0.5 millimeters to make sure that you are getting the perfect working length. So let's take a look. So I put my working length file inside the root canal, and I advance the file through the root canal, and I can see the display that I'm moving forward really well. And then I do the 0.5 millimeters, that's good, but then I suddenly stop in the last level of the display, and I have moved more than 0.5 millimeters, and I just don't get the apex reading. So in this type of situations you should guess that you are in a situation like this, that you have moved forward through the apex constriction, apical constriction. In these cases you should get back to the 0.5 millimeters and perform the measurement at the 0.5 millimeters and do a radiographic control before you go full instrumentation. So do not perform full instrumentation in these situations. Always control with the radiographic working length measurement with your patency file. The last case I would like to show to you, it's a situation where you just cannot have a constant and reliable reading from your electronic apex locator. This type of situations shows us an electronic apex locator that is with too much oscillation on the measurements, and you just cannot have any type of reading from this type of devices. So in these situations you just should avoid the electronic apex locators and perform your working length measurement just using the radiographic control with your patency file, and all the determination is based only on the radiographic control. So let's take a look. I will connect the file to the electronic apex locator and just look what happens. So I start to having very fast readings from no apex to middle measurements, and I just don't have I just cannot have any kind of measurement. I'm not even touching the file, and the device is flashing like crazy. So it's not possible to have any type of constant reading from here. So just forget the electronic apex locator on these situations and move forward just with the radiographic control with the patency file. So I hope you have enjoyed the presentation that I brought to you today, as long as the car brake videos. And I just would like to finish saying that it was such an honor to me to be part of this project. And I would like to thanks to Rui Pereira da Costa for inviting me. And I hope everyone continues enjoying the International in the Masters for the next days. Thank you.